Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Seminars. We have more than 170 videos on cardiology topics on our YouTube channel Triple N Media. You're welcome to watch each one of these, and at the end of presentation I will tell you how to get a copy of my cardiology rounds manual. The feature presentation is on cardiac output, stroke volume, end diastolic volume and pressure, end systolic volume and pressure, preload, afterload, ejection fraction, cardiac index. So we're going to understand the physiology behind all these terminologies, and in the next video we're going to talk about congestive heart failure versus diastolic heart failure and how all these parameters come into play in helping us to understand the pathophysiology in patients with various types of heart failures. So let us begin. Cardiac output. What is cardiac output? Cardiac output is basically stroke volume multiplied by heart rate. What in the world is stroke volume? Stroke volume is the amount of blood that is in the left ventricle that is ejected into the aorta with each heartbeat. Let's assume the left ventricle has 100 ml of blood before it begins to contract, that is the ventricular systole. At the end of ventricular systole, if the blood volume that is left is 30 ml, the stroke volume is 100 minus 30, which is 70 ml. So if you take the 70 ml, multiply that by the number of times the heart beats in a minute, that gives you the cardiac output, which is 5.6 liters per minute. But in cardiology, very often we use the cardiac index, which is based on cardiac output per meter square body surface area. In this way, we can correlate the cardiac output with reference to body size so that we are talking the same language. Many things can change the stroke volume. That's where the end diastolic volume and end diastolic pressure, end systolic volume and end systolic pressures, preload and afterload come into play. Let's look at a normal heart. As I said, we may have like 100 ml at the end of diastole before the heart begins to contract. But in pathological situations such as congestive heart failure, the end diastolic volume may be 2 to 3 times that of normal. In a big flappy heart, the end diastolic volume could be like 250 ml based on echocardiographic measurements. Similarly, the end diastolic pressure, which is usually between 5 to 10 millimeters of mercury, can go up in patients with heart failure, either due to volume overload or due to pressure overload. See, we are talking about volume, which corresponds to the preload, or pressure, which corresponds to the afterload, or the resistance against which the ventricle has to pump. Anytime there is an increase in end diastolic volume, it makes it so much harder for the ventricle to squeeze because one, it is dilated. Number two, it has lost its pumping ability and the geometry of the heart, so it is not able to, when the heart is small and compact, it can squeeze nicely. But a flappy heart, it just wobbles. That's why the stroke volume is, even though it is increased, but it is not an effective stroke volume in patients with heart failure. In patients with elevated pressure, due to stiffening of the heart muscle, like in patients with hypertrophic cardiomyopathy or infiltrative cardiomyopathies, the heart muscle does not expand as the blood is coming into the ventricle. As a result, the pressure goes up. And anytime there is an increase in pressure, it makes it harder or the ventricle to fill. That's why when patients with hypertrophic cardiomyopathy develop atrial fibrillation, they decompensate very quickly because their ventricles cannot fill with each atrial contraction. As a result, they develop pulmonary congestion. That's why all these numbers are very important. End systolic volume. End systolic volume is also important because in patients with mitral regurgitation or in patients with aortic regurgitation, the end systolic volume, instead of being 30, may be different because of the leak across these valves, which increases the cardiac work because now the blood has to be pushed further. Each time the heart beats, a certain amount of blood is coming back into the ventricle, so the effective stroke volume is going to be less than what is usually anticipated in a patient with a normal heart valve. So these things can vary depending upon the structure of the heart, depending upon the size of the heart, depending upon the contractility of the ventricle, and depending upon how much volume is there before it starts and how much pressure against which it has to pump. When we talk about pressure, we are talking about afterload. That is the resistance against which the ventricle has to push the blood. If the patient has hypertension, there is increased resistance to push the blood across the vascular system. Or if the patient has severe vasoconstriction, that can lead to increased peripheral resistance or systemic vascular resistance, as it is called, and it makes it harder for the ventricle to push the blood forward. As a result, either it can hypertrophy, like in patients with hypertension, or it can just dilate in patients with congestive heart failure because of increased systemic resistance or peripheral vascular resistance. And all these numbers, the stroke volume, the heart rate, the preload, the afterload, all these numbers can be measured, which will give us a very accurate information as to what is the overall cardiovascular function in a patient without even doing any invasive procedures. Echocardiography is exceedingly useful in looking at the stroke volume, looking at the end diastolic volume, looking at the end systolic volume, and also measuring preload. And from there, we can calculate pressures in chambers, various chambers of the heart, to calculate the systemic vascular resistance. In the next presentation, I'm going to talk about how we apply these principles in understanding the pathophysiology of congestive heart failure, normal heart, and hypertrophic cardiomyopathy, and talk about the systolic versus the diastolic heart failure. This has been a presentation of cardiology seminars. I am Dr. Nik Nikam, and please do watch more than 170 videos we have on cardiology topics. And if you would like to get a copy of my cardiology rotation manual, which has chock full of information about how to survive cardiology rounds and links to all these 170 videos, you just send me an email at drniknikam@gmail.com, and I'll be happy to get you a PDF copy. Please do subscribe to our YouTube channel, and I will see you in the next presentation on systolic versus diastolic heart failure.